on how to maximize your potential for good outcomes within your service area. In the next 45 minutes, I'm sorry, I might be having a bit of a technical issue here. Hold on just a second. There we go. As I said, my goal is for you to hopefully understand and discuss the unique relationships between the board and members of the key management staff. I also hope that you will know the 4 quantifiers that BPHC monitors within scope of practice, explain the differences between affiliation agreements, memoranda of agreement and understanding, and contracts, and finally to express 3 classifications that I recommend of potential community partnerships with which to seek out and build collaborative relationships. Okay, I'm going to make you a promise. That is the last slide I'm going to read to you verbatim. I also have a few housekeeping notes before we get started here. You're going to hear me use the word the Bureau quite often during my presentation. Of course, that refers to the Bureau of Primary Health Care. I'm also going to use, probably interchangeably, the words centers and health centers. These, of course, include freestanding community health centers, migrant health centers, healthcare centers for the homeless and public housing residents, and the combination of general population and special populations as well. It also includes those health centers that are FQHC lookalikes. And finally, I will be using the term state association or PCA interchangeably. Of course, these organizations go by different names, different titles. Each state has one, or each commonwealth has one, and we'll be referring to them interchangeably. Okay, here we go. I have the unique and rewarding opportunity to visit many, many health centers throughout the United States. And I always find such wonderful people doing wonderful things within their community. Dr. Jack Geiger, who is revered as one of the founders of the community health center movement, said that community health centers don't just provide health care, they change their community. And change communities they do. However, it's my opinion, after meeting all sorts of folks around the country, that you really cannot carry out your mission single-handedly. The need is just too great. I don't care if you're the largest health center in the country or a paper news start in a rural area. You must seek out and seek assistance in meeting your mission. So how do you do that? Well, first, maximize your management base, and we will examine what I have found at community health centers on how to make that happen. You also need to identify your partners, which means, and they may be few or far between. I've been to health centers that have 4 major hospitals in their service area, and I've been to community health centers where the nearest hospital is critical access and 100 miles away. So we're going to discuss how to identify those partners. Then once they're identified, of course, you need to foster strong and mutually beneficial affiliations. I'm here to tell you that probably in 90% of the time, it's the health center that must do the reaching out. Occasionally, you may get a phone call from another organization in your service area asking you to, if you can meet and maybe collaborate on something. But in talking to CEOs and boards of directors around the country, it is usually the health center that must do the reaching out. And finally, like any good relationship, it must be nurtured. I will be recommending strategies like regular meetings with your collaborators, setting up consortia, things like that, as ways of making sure that your relationships stay fresh, vibrant, and mutually agreeable. Okay. I often, for those of you who know me, I really do like, I even sometimes say love boards of directors. These are the good folks who devote so much of their time and their knowledge to the community and to the health center. And they are the ones who generate the passion for the mission. It is their mission statement. It is their goals and objectives, visions, values that guide the health center. And again, I cannot overemphasize, I've seen such boards, and they truly do exhibit tremendous passion. I like to tell boards of directors that they are the ones who put the word community in community health center. Why not? First of all, most or all live or work in the service area. Greater than half of the board members are patients of the health center, which means they are receiving their primary care from the providers at the health center. And they bring with them not just healthcare expertise, but banking expertise, finance, legal, community advocacy, education, social services. All of those different expertise are brought to the table by the board. I meet during my site visits, I meet with the boards in closed session. And I can tell you that almost always, as the board goes, so goes the community health center. If a health center is struggling or seems to have lost its way, I can tell you that it's probably because the board has done the same thing and needs to be rejuvenated. I often joke with the board when I'm meeting with them that I say, so how many employees do you have? And they all brighten up and look and say, well, let me see, 132 at last count. Or, well, we're a new start. We've only got 8 employees so far. And then I have to tell them it was a trick question. How many employees do you as a board of directors have? And of course, that answer is 1, the chief executive. You'll also hear me refer to them as either the CEO, the executive director, the project director, however your board has chosen to name that position. And the board selects and grooms and then supports their sole employee. Selection, of course, is done through a recruiting process. The board has determined how they are going to go about recruiting their CEO when an opening occurs. And of course, they conduct interviews, they review resumes, they get their selections down to 2 or 3. And of course, then at that point, the knowledgeable board knows that they are to submit the resumes of those final 2 or 3 to their project officer, not so that the project officer can select, but just so that the project officer can review and comment on things that they notice and that the board takes that aboard and uses that in their final decision-making process. When I say groom, the board must ensure that their chief executive has opportunities for training, opportunities for things like board certification, for attending NAC conferences, for making themselves available to the state PCAs, not only for participation in the PCA activities, but also to attend the leadership training that most PCAs offer. And of course, they must support them when the CEO is sometimes faced with really, really tough decisions. The board certainly supports them, helps guide them, acts as mentors when necessary in areas of finance, healthcare administration, anything that the CEO might reach out to the board members and seek. They also are required to evaluate, keeping in mind that although the CEO probably has a separate employment agreement with the board, they are also employees of the corporation in most cases, and therefore deserve the opportunity to hear from the board the type of how they are performing. Are they meeting the board's expectations? And so this evaluation is a requirement. Most people do it annually, most boards do it annually, but it could be as part of the employment agreement more often or less often, but it should be on a regular schedule basis and should be a process that involves the entire board. The entire board should be allowed to make input, let's say, to the executive committee or to the board chair, who then consolidates, maybe goes back with questions, seeks additional advice from his or her fellow board members, and then comes up with an evaluation, and then has a one-on-one with the CEO. And then, of course, the CEO then can make comments about their evaluation. Sadly, sometimes there must be a parting of the ways between the board of directors and the CEO. This does not happen all that often, thank goodness, but when it does, it can be painful and stressful. And but sometimes it's just the nature of the business in governing a community health center. I'd like to interject here something that I am now emphasizing more, and that is called succession planning. Now, people tend to refer this as CEO succession planning, and it certainly involves that, but succession and planning can involve other members of the key management staff, such as the chief medical officer, chief financial officer, and even board member succession planning. I have, at the end of this, in the final slide is my contact information, including an email address, and I have Bureau vetted documents that I am finding, that I am presenting or making available to health centers that I visit, and they often thank me, saying that, boy, they were excellent, thank you very much. We were working on formalizing a CEO succession plan. Okay, back to the chief executive officers. I consider them to be truly amazing folks who must share and take on the board's passion for mission and translate it into meaningful actions that result in desired outcomes. The key management staff, I'd like to spend a few slides now discussing the key management staff. And at a minimum, what would be expected for a community or a migrant home community health center is a chief executive officer, and as we mentioned earlier, can also be referred to as the executive director or the project director, and the chief financial officer and the chief medical officer. The latest Bureau guidance is that any member of the key management staff, including the CEO, can be contracted as opposed to an employee of the corporation. However, I cannot tell you the last time I was at a health center where the CEO was contracted and not a direct employee of the board. The reason for this is that since the beginning of the community health center movement, outside organizations were not supposed to exert undue influence on the operations and governance of the community health center, and you find that in several different ways throughout the health center. And to me, it would be very difficult if the CEO was actually an employee of another organization, but contracted to the health center to act as the CEO, that division could not possibly happen. Having said that, I have seen many other organizations that do contract for chief financial officer services or chief medical officer services. Again, and this may well happen at a smaller center or maybe a new start center where you cannot afford to hire these folks full-time right away. If it does happen, then expect during a site visit that the administration consultant will look at that contract to make sure that, number one, there is sufficient time being devoted to the health center, and also that the duties of what the board and the CEO expect are mentioned in that contract. Now, again, that was the minimum that we would expect to find at a health center, and of course, health centers do grow, and grow they do. And as the CHC grows, you often find a chief operating officer. If they have a large dental practice, you might find the dental director equal to the chief medical officer. You might find a director of nursing who is also considered part of the key management staff. Then more and more health centers are bringing IT in-house, so you'll find a chief information officer or CIO. And as behavioral health becomes a more significant part, you'll also find a director of behavioral health that is considered part. But all in all, the board and the CEO need to be satisfied that that the size and composition of the key management staff is appropriate for the size and the needs of the health center. A little bit of Org Chart 101. Many of you, I'm sure, have seen organizational charts. Most of you, I'm sure all of you have them. And without fail, the top tier is, of course, the board of directors led by the board president or board chair. Then comes the chief executive. And excuse me, then the tier of managers. Now, when I say size appropriate to the size corporation, boards of directors and CEOs need to be aware of burnout. I visit health centers where CEOs are working 60 to 70 hours a week, and then they eventually burn out and lose their drive, lose their zeal for the mission, and sometimes even look for other positions. So that's why the size has to be appropriate to the needs of the center. Let me give you some thoughts about key. Okay, I say here that there are tiers of managers, and a manager does not have to be what I would consider a direct report to be considered key. Key to me means that's the manager or director that the CEO considers part of his or her management team. And often these management teams meet on a regular schedule, let's say every week at a set time with a set agenda. The whole team gets together to share ideas, to listen to the latest policy guidance that may be coming down, things like that. And that's what I consider to be the key management staff. Again, it can be 3 people, it can be 9 people. In the special populations health centers, such as migrant health centers or homeless health centers, often the CEO will consider someone who is directly involved in the management of the healthcare to, let's say, the migrant population as being part. Even though that person may not directly report to the CEO does rely heavily on them to make sure that they are meeting their mission, let's say at the agricultural work camps or at the areas where direct care is being provided. So again, that's the ideas where that can occur. Okay, Christina, let's poll the audience with our first question.
Terrific. Okay, so like I mentioned in the beginning, I'm going to launch a question. You should see it on your screen. And you can, if you would, take a minute and you can answer. I'm going to leave the poll open for just a few more seconds. So any member of the key management staff can either be contracted, for example, 1099, or employed by the center. A, true, B, false, or C, it depends on certain circumstances. We'll leave the poll open just a little bit. About 83% of you have already voted. If you have not voted, if you could take just a quick minute. Okay, so let me close this poll. John, it looks like 67% have said true, and 33% have said it depends on certain circumstances.
Okay, thank you, Christina. And really the answer here is true. But maybe my presentation made you led to think that it does depend. But again, the answer is true. That yes, you could have all of your key management, but I seldom find the CEO to be contracted, and that's for good reason. The board does not want any outside organization exerting any influence on the CEO. So in this case, the answer to this is true. Okay, when you stop and think about it, the health center has many, many potential partners. We're going to talk a little bit about affiliates and what that means to have an affiliation agreement. And of course, the ones that are much more common are collaborators. Many health centers, in fact, I would say all health centers, have some sort of memoranda of agreement or memoranda of understanding for required services, and we're going to talk about those and how to report them and record them and how to ensure that they are correct. Some examples: transfer agreements, referral agreements, maybe a memorandum of understanding with a local nursing school for students to come and receive clinical training at the health center. But in return, the school agrees to provide a nurse facilitator, a nurse preceptor, to the health center. So again, that could be those formalized MOAs or MOUs. Of course, the state PCA is always a strong and viable partner in assisting, and again, the PCA depends on the health centers to help them meet their mission, and of course the health centers depend on the PCA as well. You have some excellent national cooperative agreements that are there to support the special needs of health centers that serve special populations. Your fellow FQHCs, and they can be formal and informal affiliations. We'll talk much more about that. And probably the biggest, strongest partner that we as community health centers and migrant health centers and homeless health centers have is the Bureau of Primary Health Care. I often explain a center's relationship with the Bureau in this way. You might wonder why the governance consultant is going to look for a statement in the board minutes that the board of directors approved the grant or the new access point or the service area competition submission or any other grants that are submitted to the Bureau. And that's because the board of directors, not the CEO, but the board of directors is proposing to enter into what I consider a contractual relationship with the Bureau of Primary Health Care. Essentially what they're saying is, if you will give us funding, or in the case of a lookalike, if you will give us a designation, we promise to do everything we've put into our grant application. So the Bureau reviews it, approves it, and they turn around and say, okay, here's the designation, here is your Section 330 funding, Now we expect you to do everything that you have said you're going to do. And probably the most important resource that you can use in this is called Scope of Practice, or PIN 2008-01. There are 4 areas that the Bureau monitors, and that's probably an oversimplification, but the 4 areas that, and that we report as part of a site visit are providers, sites, services, and patients. Notice I did not say encounters. Now, I agree with every one of you right now that says, John, productivity is vital and essential to the Bureau, I'm sorry, to the financial health of the Community Health Center. And I could not agree more. And yes, you do report encounters as part of your UDS reporting system, but the 4 that are actually monitored and reported are the 4 that I have listed here. So let's talk about each one. Providers. And by here I'm referring to licensed independent providers, or LIPs. Okay? When you fill out your new access point application or your SAC submission, you fill out Form 2, which is called your staffing profile. And you say how many of these LIPs, and they are in clinical, medical, behavioral health, and dental. And of course, any of those could be 0 if you don't offer dental services on site. And then how does that then relate to your most recent, and in this case, 2014 UDS submission? So that's one comparison that is made. The second is sites. All of you are familiar with Form 5B. And during a site visit, those will be reviewed for accuracy. And I would like to say just a word or two about mobile vans and subrecipients. The latest guidance that I have is that, yes, mobile vans are to be listed on Form 5B, but assuming that actual encounters or provided by an LIP is performed on board that mobile van. If it's just a small trailer, let's say, that you may tow to a health fair that has a table that you can hand out stuff like that, no, that is not considered a mobile van. That is something else. The other thing, though, and again, I'm not a fiscal consultant, but I'm told that that mobile van does not have to have its own Medicare billing number. It can use the Medicare billing number of the main site out of which it operates. The decision on whether it needs a Medicaid number is, of course, up to your state Department of DMAS, or Medicaid Services. Also, subrecipients. There are subrecipients. They must be, if you have one, they must be listed. That is, a subrecipient is defined as someone to whom you literally take some of your Section 330 funding and give it to another organization. In return, that organization reports UDS data back to you to report as part of your overall UDS. There has been a lot of changes lately in subrecipients. Subrecipients must be able to meet the same governance requirements and sliding scale requirements, and by some standards, all 19 program requirements as the main center. So I'm here to tell you that, in my opinion, that unless you are subletting or considering having a subrecipient, if it's not a fellow FQHC, and I've seen this work in the cities and especially with special populations funding, you're probably not going to be able to meet this program requirement, because it would be almost impossible for another organization to meet all of the program requirements. Services. Probably the most difficult thing that I have seen in my health center site visits for the last, 6 months has been Form 5A. Form 5A, as you know, has 3 columns, and you put X's in those columns, and those Forms 5A are closely audited by the clinical consultant during a site visit. As you might recall, last June, the Bureau announced and carried out a scope alignment project, which allowed health centers time and the capacity to make updates to their scope through their Form 5, all 3 sections. On the slide, I have a link to, and I need to correct that link. Something has just changed. If you go straight with that link, you're probably going to get to a website that is just a bunch of gibberish. I'm going to read it for you if you have a pencil, or if you want to email me at the end, I'll give you the actual thing, but it's http:// and then it's bphc.hrsa.gov/program requirements, all one word, /scope.html. Again, rather than spend any more time repeating that, if you weren't able to get that, please just email me at the end and I'll be happy to give it to you. But what that does is explains and gives very definitive guidance in what goes into each column. The examples that I've been hearing lately is very interesting, and the one that is probably the least understood is what can go into column 1, which are health services essentially that are provided on site by the grantee. Let's take OB and prenatal care. If a health center provides prenatal care on site using their family physicians, and maybe even hire a nurse midwife to assist and do that, of course that goes in goes in column 1. Because those people are indeed, and I'm going to underscore, employees. They are salaried employees of the health center. Let's say that health center then goes out and contracts with an OB practice, and an obstetrician under contract comes in and performs services at the health center. Okay, that is still a contract in which the grantee pays, and therefore it goes in column 2. Then if you refer out, let's say, a complicated or high-risk pregnancy, and you do not pay for it, then that can go into column 3. So in that one instance, you would have X's in all 3 columns. Patients, okay? Patients are considered general and community and special populations, and again, when you are back filling out your SAC or your service area competition or your new access point, you have Form 1A projections. And then, of course, you report the number of patients you have through the UDS report. These are provided to the Bureau, again, by the UDS report, and again, they're reported. And although the Bureau no longer issues grant conditions or anything based on patient numbers, be aware that you must be coming close by the end of your project period to meeting those projections, or you could have the size of your grant could very easily be impacted. So again, it's something that you must keep track of. And then also there is Form 5C, which is other activities. That's where you list hospital admissions, rounding, let's say in nursing homes, other things like that. So it's just important that Form 5C be kept current, and all entries on Form 5C are considered self-updates and are very easy to do. I would refer you to the PIN for examples of those other special activities. Okay, Christina, let's poll the audience with our second question.
Okay, terrific. Let's see here. So I'm going to launch the poll question. Which of the following is not measured by Bureau of Primary Healthcare in monitoring scope of project? Please select one. A, services, B, patients, C, encounters, D, special populations patients, E, providers. We'll leave the poll open just a little while longer. About half have responded. A few more seconds. We've had 83% vote or respond. Okay, John, I'm going to close the poll. It looks like 80% said C, encounters, and 20% of those who responded said E, providers.
Okay, the correct answer is encounters. So again, encounters, and even though you do report encounters, the Bureau does not monitor encounters or set standards for encounters. And Christina, lest anybody thinks they can take a break or start their 3-day weekend early, let's poll with question number 3.
Sure, here we go. So, in what ways is progress and compliance with scope of project reported to the Bureau of Primary Health Care? Again, if you would, please select one. A, triennial OSV site visit reports. B, Form 5, that's parts A, B, and C. C, the UDS, or D, all of the above. I'll leave the poll question open just a little while longer, just a few more seconds. We've had about 67% of our participants respond. If you could take a minute and respond for us, please. John, I apologize. For some reason, it did not give me our, I did have 83% who voted, but I did not get the results. I apologize.
Well, that's okay. The answer is indeed all of the above. And again, it's reported as part of our site visit reports. You keep Form 5 pristine and current all the time. And of course, in your annual UDS submission, these those are areas such as patients and things like that are reported as well. Okay, let's continuing on now, getting to the heart of our presentation, which is who are our partners. Affiliation agreements. Very quickly, because very few health centers have true affiliation agreements, understand that there is a PIN 9727 that talks about it, and essentially it's when two organizations, one of which being the community health center, actually forms a new entity with maybe another organization that also desires to meet their mission by partnering closely with the community health center. I have seen very few of these around the country. I have seen one where a community health center formed an affiliation with a tribal entity that was not a recognized tribe. So therefore, they were not part of the Indian Health Service, but they were able to work together like this, and they actually shared some of the governance responsibilities with the tribal council, things like that. I've also seen, and this may be increasing, more behavioral health organizations actually forming entities where you might find common staff, common buildings, common things like that in order to do that. But again, you do not find many of those around the country. What you do find are many, many memoranda of agreement and memoranda of understanding namely those formalized, that formalize. And this next statement, I'm not going to read it to you, but I do read it as part of the exit conference when I am there because it is that important. Health centers cannot seek out and form something and get a really good deal, but in return give up something that they're not supposed to give up. They can, such as undue influence on the board of directors, or appointments on boards of directors, or we demand to see your payer mix and we're going to take away this good deal if we don't like your payer mix, things like that. And you can see how important that is. Again, I cannot emphasize more that that community health centers were meant to be autonomous and not be under the influence of other organizations. I've already discussed subrecipients in a previous slide, but again, I will emphasize that it's very difficult for an entity to be to meet all the requirements of being a subrecipient and not be an FQHC themselves. Having said that, I've seen some very excellent subrecipient relationships in the areas of special populations, where two health centers can work together in meeting, let's say, healthcare for the homeless or migrant health, agricultural worker health things. I like to look at collaboration for three different areas. The first, of course, is the greater healthcare system present in the service area. Again, there may not be much, but there's going to be one or two entities, or you may be collaborating with 4 hospitals, 2 universities, some private practices, and a local medical school. How well you integrate it, keeping in mind that the purpose of the collaboration is to enhance the care provided to the patients, and also to allow the community health center to perhaps provide care to additional patients that may be seen elsewhere. The other area is the second area I look at often are other safety net providers. These can be health departments, homeless shelters, family shelters, faith-based initiatives such as parish nurses. Many churches have a parish nurse program and may discover a parishioner who needs help and can't afford it and needs to be able to refer into the community health center for that patient to get that help. Free clinics. There are still many, many free clinics around the country, and I often find where a well collaborating health center will stay in touch with that free clinic and say, hey, we know that you provide great service to this family, this working family, for example, and we applaud you for that. But please, know that we're here, that if things start become, like if a child needs the specialized care that your provider positions cannot provide, then please, by all means, call us and we'll get that child worked in as soon as we can. And of course, rural health clinics as well. So there is that. And then, of course, collaboration with state primary care associations. We've already discussed that at some length. And then, and probably the one that I look at and discuss with the CEO are fellow FQHCs and lookalikes who are maybe sharing the same service area, or there's 3 in the same city, things like that. I have seen some excellent formal collaborations. That's where there actually is paperwork signed and maybe even another 501c3 formed, where they can be informal. I hesitate to sometimes give specific examples, but if you go to Detroit and Southeast Michigan, those community health centers actually meet about once a quarter. The CEOs get together and they actually perform joint strategic planning, where they take underserved areas of Southeast Michigan, examine them as a group, and then decide who is going to write the NAP for that particular one. and that's an example, let's say, of an informal collaboration. And you're always expected, when you submit your SAC, to get letters of support from your fellow FQHCs. Honestly, it always saddens me when I find a situation where nobody's talking to each other, they're in competition with each other, and again, that really does, to me, not serve the population that needs to be served. I heard Mr. Jim McCrae, the acting HRSA administrator, express frustration at service area overlap and wished that more health centers would collaborate and say that the need is there, it just needs to be brought out and done. One last thing, to go back just a little bit, because this just sort of happened last week, and that is contracts. The Bureau has requested that it's all part of the program requirement that the health center has a written board-approved policies and procedures on contract administration. Now, during the site visit, that's a yes or no question. Yes, they do, no, they don't. And if it's yes, they do, as part of performance improvement, we look at it and offer suggestions on how it might be improved. In particular, what came out last week was not all, sometimes the Bureau, the policy does not specifically designate who should be signing those, and it could be the chair of the board, it could be the CEO, it could be the CFO, but I strongly recommend that the board of directors and the CEO establish maybe monetary limits as to who can sign what, and also make sure that in most cases, the CFO is the central repository of all signed contracts, so that he can set up a tickler file as to when they're going to expire. Do they have an evergreen clause? Things like that. Because especially in the world of information technology, many health centers have outside contractors for that, and that can be right pricey. And then all of a sudden they start bringing in into the in-house, if you would, IT, and yet the contract is not modified, so they wind up paying twice. So that's just a last-minute thing under contract administration. Okay, Christina, last question.
Okay, let's try this. Hopefully we'll get the results that come through. So I just launched the question. So geographically close FQHCs must enter into formal collaborative agreements with each other to maximize mutual support. So please select an answer: A, true; B, false. It looks like our results are coming through. Fantastic. And 83%, everyone said 83%, I'm sorry, say B, false, and 17% said A, true.
And the answer is B, false. The word here, of course, underlined is must. There's nothing that makes co-located or geographically closed FQHCs enter into formal agreements. But in my experience around the country, health centers that do meet together periodically and conduct joint planning or things like that certainly benefit each other as well as the service area. Okay, I'm just about finished here. What we talked about is the role of the board in the passion and direction of the health center, how they select their sole employee, who is the CEO, who in turn selects the key management staff and works with that key management staff. We talked about many key partners that you can have, and they are, of course, the Bureau, affiliates, and those, by that I mean people with whom you have a formal affiliation agreement in accordance with PIN 9727, contractors, and then collaborators with whom you have a formalized MOA or MOU. So all of that working together will hopefully result in your mission consistently accomplished. I'm now, I think we're on, oh gosh, we're almost finished. I have a few minutes now available for any questions or comments. Christina, are there any?
I have not had any questions come through via the chat feature. However, if anyone would like to ask a question, I think we have about 5 minutes that we could do that. You could use your hand raising option. But if not, no, John, we don't have any questions that have come through. So again, as we mentioned at the beginning, you can send those to us and we will make sure that John gets those questions.
Yeah, thank you, Christina. I've listed a few. There are many, many resources. I cannot overemphasize the Health Center Program Site Visit Guide. This is all, of course, available on the Bureau website. The guide lists the questions that you need to be familiar with and how to prepare for various site visits, but there are other pins as well, and I would certainly recommend that you become familiar and with them. And as promised, there I am. That's my home office phone. If you call it, you're liable to have a nice chat with my wife if I'm out on a site visit. But I prefer to actually be contacted by email.
Okay, thank you, John, so much. That was wonderful information. We'll make sure that you get some get the questions that come through maybe later. We have about, John, I have one question that did come through. We have about 3 minutes. So our MOA, or required for services not directly provided by the grantee. I guess I don't understand.
Can you repeat that?
It says our memorandums of agreement or required for services not directly provided by the grantee.
Yes. If it's, as I understood it, for required services and they are not provided, there must be either a formal contract, let's say, or a memorandum of understanding or an agreement. Again, the key thing is column 2 or column 3, where you put the X for how you provide that service. Column 2 means you pay. An example would be your lab contract, Quest or LabCorp or with the local hospital, and you pay for that for your patients, and that way they can benefit from that, either using your sliding fee scale, something like that. So you pay for that. That would go in column 2, or you refer them out, but you do not pay for that, then that would go into column 3. I think what the participant may be asking is, can you have an MOA for a required service and have it in column 3, which means the grantee does not pay? And the answer to that is yes. Again, I'm not a fiscal consultant, but the MOA must contain all of the language that is contained in PIN 2014-02 sliding scale. And many health centers around the country are struggling with this because you must ensure that that contractor or that referral resource is providing a sliding fee methodology to your patients that is at least as good as what you provide. And this is being looked at all across the country and is being, I can promise you, being examined by the Bureau of Primary Health Care, and you can probably expect more information on that in the future.
Okay, thank you. I don't have any other questions that have come through, and it looks like we have a minute to spare. Actually, it's exactly an hour, so we can start our holiday weekend or our long weekend. Thank you, John, so much for joining us.
Thank you, Christina.
No problem.